And the first section that we're going to talk about is pulmonary disorders. And so we'll start with that. And here's how I have everything set up for you. I'm always going to give you an overview. In other words, I'm going to tell you what we're going to talk about. We're going to talk about it. And then at the very end, I'm going to have multiple choice questions for you that will help you assess your mastery of this information. If you miss all of the questions at the end, don't panic. Well, you might, but don't panic. It simply means that this is an area for you that needs more review. So we'll do that with you with every section, and it should give you a good idea of where you need to begin to spend some time studying. So in the realm of pulmonary, here's what we're going to talk about for our next 70 or 75 minutes. I have to make sure that you know all about cough. What you ask, what you look for, what are the clues you need to look for? So we'll talk about that. And then we're going to move to pneumonia. If you've spoken to anyone recently who's taken the exam, you probably have heard that there are 3 or 4 questions on pneumonia. It's a big deal. We got to talk about it. And then the remainder of our time, we're going to spend talking about the 2 most common chronic pulmonary disorders. You know those as asthma and COPD. And so we'll spend a lot of time on that. There are questions on both exams about COPD and asthma. All right, so I've got to make sure that you're ready. Let's get going. So I'm going to start out by giving you a patient. And here's your very first one. It's a 36-year-old who has a chief complaint of cough. And my first question to you is this one. What's the most important question for you to ask that patient? The most important question to ask any patient who presents with a chief complaint of cough is always, how long have you coughed? Now, why is how long have you coughed the most important question to ask? That's the most important question to ask because once you get an answer, you'll know how to build your differential diagnosis. You know what I tell people all the time? You know the difference between a good nurse practitioner and somebody who just passes the exam? A good nurse practitioner is always someone who can build a good differential. When you ask a patient, how long have you coughed, it helps you build your differential. So listen, if they tell you, I've coughed less than 3 weeks, your differential will probably look like this. Maybe they've got bronchitis. Maybe they have an exacerbation of their asthma. Maybe they have pneumonia. But if they tell you they've coughed longer than 3 weeks, then your differential is going to look very, very different. If they tell you they've coughed longer than 3 weeks, I am pretty sure that asthma and GERD are going to be part of your differential. You know why? Because asthma and GERD are the 2 most common reasons people cough longer than 3 weeks. So that's got to be part of your differential almost always. But maybe it's an ACE inhibitor cough. Maybe it's somebody with chronic bronchitis. So do you see how you build your differential based on that one question that you ask a patient who presents with a cough? Is everybody with me? All right, let's keep going. I'm going to give you a lot of patients to take care of over the next 2 or 2.5 days. And here's your very first one to take care of. Here it is. A 24-year-old college student who is a non-smoker and otherwise healthy has been diagnosed with pertussis. What's an appropriate treatment for her? Well, what do you know about pertussis? It's highly contagious, it's a reportable disease, and it's one of the few times when we treat acute bronchitis with an antibiotic because pertussis produces acute bronchitis. So let me ask you, how do you treat pertussis? We always use a what? A macrolide antibiotic. What's the example of a macrolide up here? It's number 2, azithromycin. Azithromycin is your best answer. I think you're going to see that again on an exam. I know that you'll see it in clinical practice because we have pertussis outbreaks all the time. All right, so your best answer is number 2. I am leaving acute bronchitis. I'm moving to pneumonia. You ready? Pneumonia is a big deal. The kind of pneumonia that you need to be prepared to answer questions about on your exam is called community-acquired pneumonia. Some people call it ambulatory pneumonia. All right, so you'll hear both those terms. The reason this is a big deal, not just in your clinical practice, but on the exam, is because when people get pneumonia, a lot of them have bad outcomes, meaning there's a high rate of mortality. And even if there's not a high rate of mortality, it costs a lot of money to get the people with pneumonia well. So it behooves you to know how to manage these patients. Well, it all starts with knowing the most likely bug. In fact, there are 3 bugs as etiologic agents of pneumonia that are so darn important, I can't let you leave today without knowing them. Their first and their last names. And one of them you even need to know the nickname of. All right? So listen to the name of the first bug you cannot leave here today without knowing. The name of the bug is Streptococcus pneumoniae. Its nickname is strep pneumo. When patients come in with strep pneumo, you better have a heads up. That's a bug that's most likely to kill your patients. Consequently, when a patient comes in with pneumonia, strep pneumo has always got to be on your radar screen. The second and third bugs that cause community-acquired pneumonia that are so darn important, I got to make sure you leave here with their names, belong to a group called atypical pathogens. Now, atypical doesn't mean unusual or rare. Atypical is the way it probably appears on chest x-ray. Let me make sure you know the names of these 2 atypical pathogens. One of them I know you'll know. It's called Mycoplasma pneumoniae. Mycoplasma. When somebody says, oh, I have Mycoplasma pneumonia, that's what they've got. What's another name for Mycoplasma pneumonia? Walking pneumonia, exactly. So when someone says, I have walking pneumonia, it's Mycoplasma, an atypical pathogen. The other atypical pathogen that is very common is Chlamydophila pneumoniae. It's also an atypical pathogen, but it's pretty darn common as well. So why do you need to know the atypical pathogens? You need to know primarily those 2 because they are the most common causes of pneumonia. You got it? So you got to know strep pneumo because that's a bug that's most likely to kill your patient. But you have to know Mycoplasma and Chlamydophila pneumoniae because those are the most common bugs that cause pneumonia in young and middle adults. Everybody with me? Can everybody leave today? You got those 3 bugs, all right? Let's keep going. The reason you have to have a good idea of what bug a patient has is because that's how you know what antibiotic to give them. And so when we look at bugs that cause pneumonia, I want you to think of them like this. I want you to think of strep pneumo as one of the bugs that causes pneumonia. In fact, it's not just any old strep pneumo. You know what it is? It's called drug-resistant strep pneumo. The acronym we use to describe that bug is DRSP, drug-resistant strep pneumo. So when you hear people say, oh, that's DRSP, you need to think, that's the bug that's most likely to kill my patient. We always compare and contrast that with the atypical pathogens like Mycoplasma and Chlamydophila. Let me show you why you need to have an index of suspicion about what bug it is. When we look at who's most likely to have DRSP, you know who it is? Look, older, sicker patients. When we look at who has atypical pneumonia, it's somebody who's young and otherwise healthy. A big contrast in who typically gets these organisms. When we look at the symptoms they present with, when a patient has DRSP, that's your classic presentation of pneumonia. Man, they look sick. They come in with fever, cough, chills. They look sick because they are. When a patient has atypical pneumonia, they don't always have that very acute presentation with very high fever. A patient with atypical pneumonia like Mycoplasma might have a low-grade fever. I feel tired today. I'm having chills at nighttime. I'm very low energy. And look, I have this rash. That's a common presentation of mycoplasma. So the way these patients look is very different. So there's something I want you to do that kind of has a negative connotation. You know what I want you to do with patients who present with pneumonia? I want you to profile them. I want you to profile them. So when an older, sicker patient comes in to see you and they have pneumonia, what bug are you going to suspect? DRSP. If it's one of us, a young middle adult, we typically think they come in with an atypical pathogen. You got it? So do you see why it's so important to profile these patients so you know what bug they have? Once you have a good idea of the bug that they've got, you know what the best antibiotic is to give to treat them. All right? So I want to make sure that you can see the comparison and contrast between these two sets of bugs. All right. Take a look at this question. I really don't expect you to know the answer. But there's an important reason I have this question in here. Take a look. A 54-year-old patient who is otherwise healthy and takes no meds has been diagnosed with community-acquired pneumonia. The question is, what's an appropriate treatment for her? Well, the first question you have to ask yourself is, I wonder what bug I'm treating. What bug do you think she's got, DRSP or an atypical pathogen? An atypical pathogen. She's a middle adult who's otherwise healthy. When we treat atypical pathogens, we use a macrolide or doxycycline. But I bet you're sitting there thinking, oh, I know the answer to this because when I did this in clinical practice, we hit them with Levaquin. Don't you dare do that. So listen, one of the most important things I can teach you if you are getting ready to go in and take this exam is this very, very important point. Here it is. You ready? Every question on your exam has got to be answered either based on a national guideline, a standard of care, or a big old body of evidence. Every question on your exam has got to be answered based on that. The last thing I want you to do is answer a question on your exam based on what you saw done in clinical practice. All right? Because I'll bet you every acute bronchitis patient left your office with a prescription for an antibiotic. And you know that's viral. And I'll bet you when you saw a patient who came with pneumonia like this lady, she probably got your big gun quinolone. All of the data says give them a macrolide or doxycycline when they look like that patient, all right? So answering the questions based on a national guideline or a standard of care will be the most important piece of advice I can give you as you go in to take this exam. All right, everybody with me? All right, let's keep going. So how do you know what to give them? Well, it's a big deal. You got to profile patients and figure out what's the most likely bug they have. So let me tell you how you know what to give. We have these guidelines that tell us how to treat pneumonia. And you might be looking at the date of those guidelines, and you might be thinking, Amelie, that says 2007. That's 10 years old. We must have a newer guideline. Nope, we don't. But you need to believe these guidelines, and you know why you should? Because these guidelines are put together by two of the most famous organizations that deal with lung infections, the American Thoracic Society and the Infectious Disease Society of America. They got together in 2007 and made these guidelines. Well, every year since then, they have reconvened. They relook at the bugs that cause pneumonia in the United States and the antibiotics that kill those bugs. And every year since 2007, they have come back and said, the guidelines are still good. So although they have a 2007 date on them, I want you to believe them. So let's talk about what they say. In a nutshell, take a look. If a patient is otherwise healthy, young or middle adult, that's most patients, then we're going to give a macrolide or doxycycline. If you suspect DRSP, drug-resistant strep pneumo, in an older, sicker patient, the bug you suspect is DRSP, and your go-to drug class is going to be a respiratory quinolone. Everybody with me? So that's exactly what you're going to do in a nutshell. Do you see why it's so important to profile your patients? Because it makes you make a good decision about what antibiotic to give. All right? So let's keep going and let's take a look at this patient. A 55-year-old patient was diagnosed with pneumonia 7 days ago and was started on levofloxacin. He's had normal temperature for the past 2 days, but he complains that he still feels tired and he's coughing. How should this be handled? Well, let me ask you something. He's 55 years old. He was put on levofloxacin. I am thinking that although he's considered to be a middle-aged adult, he probably has other stuff going on, like a bunch of comorbids, because that's somebody who we suspect having DRSP. He's been afebrile for how many days? 2 days. What do you think his temperature is going to be on the third day? Like normal again. Does he need another day of antibiotics? No. What does he need? He needs more time, right? He needs rest for a couple or 3 or 5 or 7 more days. So here's what you have to tell patients. When someone has pneumonia, I want you to think about this. They have an infection in a major organ in the body. If a major organ in you is infected, people usually feel pretty sick. Consequently, sometimes people need a little more time. You don't need another chest x-ray. He doesn't need 3 more days or 5 more days of an antibiotic. He needs to rest. All right? So be patient and don't always be willing to throw a drug back at him. You got it? Everybody with me? You see where I'm going with it? All right, let's keep going. Look at this one. Which characteristic is least likely to prompt you to consider hospital admission for an adult patient who has pneumonia? You know what I'm asking you to do? I'm asking you to see a patient in your clinic and look at him and think, oh man, he's too sick for me to send home. What would make you say, with a pneumonia patient, I can't send them home, they're too sick? Well, if they've been confused since they've gotten pneumonia, you can't send that patient home. If they have a respiratory rate of 30, they are huffing and puffing. You can't send that patient home. They need to be admitted. What are you thinking of with a blood pressure of 80/50? I'm thinking of sepsis. You can't send that patient home. But look at number 4, because that's your best answer. Least likely to make you consider hospital admission would be age. But I'm going to tell you something. If somebody is 65 and older, that's the age at which the guidelines begin to say you need to consider hospital admission. So this question really goes straight to the recommendations from the guidelines about when to get people admitted to the hospital. All right? So best answer, number 4.